Hi,
Hello.
can you hear
Can
me?
you, I can. Can you hear me?
Yes.
Perfect.
This was a very stressful thing to set up.
I've never done IG Live before,
I
ever.
have, but
Guest.
yeah, exactly. So also it's been I don't know if you can hear it in my voice, but it's been a very fun and stressful day.
I can
So
imagine.
how are you? You okay?
I'm good. How are you?
I'm good. I'm good.
That's good.
So yeah, thanks for joining me on this IG live. This is my second IG live, so I'm kind of a veteran now.
You're better than me.
So hi everyone who has joined. My name is Grace, and this is Dr. Damije, and she's a board certified endocrinologist. And we just want to talk about menopause generally, especially as it intersects between primary care and endocrinology. And you're in the United States, and I'm in Canada, so things are kind of different, I guess is the word, in the sense that we have a different kind of healthcare system. So I guess in our conversation we'll talk about the differences in like who sees like menopausal patients, for example, in both countries.
Sounds
So
good to me.
cool. I'm excited. So how should we start? Um, should we start with, I don't know, should I ask you some questions?
Yes, I think you can ask me some questions, and
Okay.
as we're going through it, we can flesh it out and see
Yeah.
what's interesting and what's different, where the similarities are and where the differences are. At the
Okay.
end of the day, women are the same all over the world. So how we practice how we practice medicine can be slightly different, but we're still treating the same women all
Yeah.
over the world.
Yeah.
Yeah.
So can you tell me a bit about your practice? Like which patients do you generally see? Do you generally take referrals or do patients come to you directly?
So in my practice, I work in a hospital-based system. So I'm one of two endocrinologists in the practice, and I have personally taken an interest in women's health. My partner is a male, and he doesn't typically like to deal with those kind of things. So if a woman shows up and he doesn't want to deal with it, he'll refer them to OB-GYN. But since I joined the practice, I've been taking on more women's health patients, but patients still have to be referred to me by their primary care.
Okay.
I don't think that a patient can just come in to see us without a referral. They do need a referral.
Okay. And then how does it work in terms of insurance? The insurance would cover it.
Yeah, if it's their primary care who refers them and we review the referral and we accept them, then they will be covered by their insurance. I
Okay.
don't we don't do self pay. Most people go
Okay.
through insurance. Yeah.
Okay. Okay. I think it's kind of similar for us. It's just we have a single pay. Like everybody should be covered if you're being referred. So I'm a primary care physician. I have
Yeah.
a I have a panel of my family practice patients, but I also do menopause care. I do women's health generally. 1 day a week, I see lots of women for lots of different like women's health issues. But for my women's health clinics, you have to get a referral from somebody else because I need somebody to um, continue for continuity, basically. So
Mhm.
you will need a referral, but once you're referred, you're also like it's covered by
Yeah.
the government.
So it's kind of
So
similar.
it's kind
Yeah.
of similar. Yeah, it's similar. So I guess the first question I would ask you is about estrogen and other hormonal changes that happen during menopause. Like we focus on estrogen a lot, but are there any other kind of hormonal changes that would contribute to the general symptoms? So like the hot flashes, the night sweats, the mood swings. What other hormones should we be thinking about?
Absolutely. There are lots of other hormones that, are very well impacted during the perimenopause and the menopausal transition in a woman. Although estrogen seems to get all the attention, progesterone is a very important hormone. And as a matter of fact, it's one of the hormones that decline even before estrogen. So it's one of the hormones that is very impacted in things like your sleep and your mood. So one of the first things that a woman will first start manifesting with it will be poor sleep, and then they start telling you about their mood, like they're more anxious, they have more anxiety, they're very irritable, they don't have patience and things like that. So that is the progesterone dropping. Other hormones include things like testosterone, as you already know, that can affect your libido, it can affect your muscle mass, can affect your energy levels. And if a woman is presenting with loss of libido, if that's a primary concern, it probably is the testosterone that is driving that woman's perimenopause. Another hormone is your cortisol and your insulin. Insulin becomes more resistant. You can become more insulin resistant as you go through the perimenopausal stages, which can lead to things like weight gain, can lead to things like, that central adiposity. You hear women come in and they're like, since I hit menopause, I've
I
had this
can't lose the
tag.
weight around my belly.
I just can't lose that weight around my belly. Normally, if I, cut out bread and cut out rice, I'm able to lose the weight. But since I hit menopause, it's just not bulging. That's insulin resistance. All those hormones are very important, and it's important for you to know which one plays what role, so that when a person is talking, you're not just focused on that estrogen.
Estrogen.
Mhm.
That is super important. I think estrogen is like she's the lead actress, and we sometimes see the other ones as supporting actors, but sometimes without the supporting actor, the movie is not gonna it's not gonna
Mm-mm.
hit. So
Mm-mm.
yeah, thank you for that. And then so I wanted to talk about, so we were kind of focusing, for those of you who just joined, hello. We're kind of focusing on the SWAN study. So I'm just referring to my notes that I've taken. So basically, this one study is the study of women's health across the nations, and it is the largest the largest study of women going through the menopausal transition. It's been going on for decades. And what we actually wanted to talk about, our main focus of this evening, is focusing on Black women, like the burden of menopause on Black women, and see how they are, like, see how Black women seek help and how they are offered help, that kind of thing. So this one study said on average, Black women experience hot flashes that are more frequent, more severe, start earlier, and last longer than their Asian or white counterparts. And that is like it's an established fact. We're not guessing here. It is actual, like, studies of thousands of women. This is not just like a one-off kind of thing. So I mean, thinking about that, how much of the burden of menopause do you think is biology versus chronic stress? So you and I know that we're a minority, in at least in North America generally. So that can put chronic stress on women. How much of that do you think is chronic stress versus natural biology, just because you're a Black woman? Do you think it's one or the other, or do you think it's a combination of factors?
That's a great question. I don't think it's one or the other. I think it's both. I think that Black women, as you said in the SWAN study, that's the study of women's health across the nation. It has proven to us categorically that Black women tend to experience more severe symptoms. Their symptoms tend to start earlier. And it actually, we know that there is also the bias, the prescribing bias. Black women don't tend to seek care. Black women don't tend to get even the care they deserve when they eventually seek the care. So it's both the biology, there's the socioeconomic part of it, there's the bias, there's the prescribing bias, there's just a lot of things that combine together that make menopause care worse in women of color.
Yeah, I agree. I definitely agree. I think it's both. And my mom is visiting actually. And I remember when she was going through the transition, it was really rough. So I'm going to bring her on my channel and interview her based on her race. And because she didn't seek any help, because she didn't think that she was supposed to. So part of that is conditioning. I think it's both. I would strongly agree with that. So how do you test for other hormones in your practice?
Well, as we said earlier, we've talked about the hormones that are affected. I don't typically test for every hormone. Then you know very well that the hormones are not reliable, especially in the perimenopausal transition phase. I don't typically screen for progesterone or testosterone. If a woman tells me that she's having hot flashes, if she tells me that she's having poor sleep, if she's around 35, 45, and I've ruled out the thyroid, I've ruled out other conditions, I don't need to test any hormones for me to know that the woman is going through perimenopause. If the problem is mostly geared towards like poor sleep or, mood problems, then I know that's a progesterone problem. If it's more about hot flashes or night sweats, I know it's more estrogen driven. If it's libido, like, I can't seem to, I'm not interested, I just have no desire, I know it's more testosterone based problem. Sometimes I will check FSH and LH just to help me. But even if that comes back normal, it doesn't rule out anything if the woman in front of me is complaining about all the symptoms. So, sometimes I'll check the progesterone for the heck of it. Testosterone is completely unreliable. It can be in a normal limit, it can be in a low limit. It doesn't tell me anything. I go mostly based off of symptoms.
Yeah, I think, yeah. So basically, in other words, treat the patient, not the numbers. And I think I would agree with you, at least in Alberta where I practice, the testosterone is not very, it's got like the normal level is supposed to be low with women. So like,
Exactly.
so I would only do that if I'm monitoring a testosterone therapy. I wouldn't just randomly do that. But other hormones, I think, like you said, it's blood work if you're doing like the thyroid and the cortisol. The others are not, as you said, that reliable. So I want to talk about metabolic health because I think that we are underestimating it. What do you think?
Absolutely agree with you. I think that this is the one part of women's health where endocrine and primary care need to communicate better. Menopause is a lifelong transition. It's a decades long transition. A lot of people see menopause as, it's the stop of periods. Once your periods stop, but it goes way beyond that. It goes deeper than that. We know that it causes increase in visceral fat. We know that your cholesterol changes. Your LDL, which is the bad cholesterol, tends to go up. Like clearly, you can see a woman from 1 year to another year, and their LDL is completely different. And the only thing that changes is that they're now in perimenopause or they've gone through menopause. Another thing that I've personally noticed in my practice, I don't have a study to support this, but I know that lots of women develop thyroid problems when they're going.
Wow.
Yeah.
Interesting.
Yes. A lot of them have Hashimoto's hypothyroidism. It's an autoimmune condition whereby, you have these antibodies that are attacking your thyroid. But for a long period of time, the antibodies sit down dormant until the body goes through profound stress. The two times that I've noticed that women tend to get diagnosed most is in the peripartum period and then the perimenopausal period. So most of my patients are like young women that recently had a baby, 4 months postpartum, 5 months postpartum, and women in the perimenopausal stage. I've noticed, I don't have a study to support
because
this.
no, literally, now that you're saying it, I'm seeing it. I'm seeing the pattern. Now that you're saying it, I didn't really put it together before.
Yes. I've noticed this, like lots of women, peripartum and perimenopausal.
Awesome.
Yes.
Wow.
I probably need to put a study together around this.
Yeah, that would be
or
good.
look for a study. I'm sure
Yeah.
somebody must have done something about this. Another thing that you want to pay attention to is bone health. Lots of people, oh yes, lots of women are dismissed. They're like, oh, when you get to 65, we'll do a bone density scan. But I think that if a woman is going through early menopause, it could be surgical menopause, could be, premature ovarian insufficiency, they should be getting a bone density scan done.
100%.
We don't have to wait till something breaks before we do that bone density scan.
So yeah, I definitely agree with that. And I think that my question actually feeds into the next question I had, which was about long-term. I think we should be talking about menopause as an endocrine transition rather than just, because I feel like once people hear menopause, it's all about, oh, your periods have stopped. but beyond the period stopping, it should be it should be an endocrine transition in my opinion.
You are absolutely right.
Yeah.
You are absolutely right. Menopause is not just about the period stopping. It can start years, up to 10 years before your final period. Perimenopause can happen up to 10 years before your final period. And all of the symptoms that happen with menopause can also start in perimenopause. Hot flashes, night sweat, poor sleep, mood instability, joint pains, bone health, cholesterol issues, all of these things. We should be talking about perimenopause and menopause the way we counsel about cigarette and alcohol. We literally should be talking about that.
I agree. Let me tell you, I totally agree. I 100% agree. Because when it comes to metabolic health for women, and I think this is an important thing that I want women to take away from here, is just because your periods have not stopped does not mean that you cannot get treatment for the perimenopausal symptoms that you're having.
That's right.
So
that's right.
Because like Dr. Dam just said, it can be 10 years before your last menstrual period. And we don't need to be suffering for those 10 years. So yeah. Anyway, those are the questions I had for you. Do you have any questions for me?
I do have a few questions.
If you guys have any questions, you can put them down in the comment section below and we'll try to answer them. We're just trying to have a conversation about women. I feel like I'm on the hot seat.
Yes, you're next. So I would love to ask a genuine question, because most of the patients that are referred to me, they've already been screened by primary care. Somebody, maybe their primary care, their OB-GYN has already screened them and referred them to me. Half of my work is done. I'm not doing the digging, trying to figure out, is this perimenopause? Is this stress? Is this thyroid? I'm not trying to do that. So I don't know, how many minutes do you get with a patient, and how easy is it for you to clock it? Like, is this woman in perimenopause or that kind of situation?
Yeah, I think again, because I kind of intersect between I'm certified by the Menopause Society, like the International Menopause Society. So I feel like because I've been doing this for a few years, it's quicker for me. I'm more efficient with it. But generally, I use and this is what I tell my students as well that shadow me, I use the M6 questionnaire. It is basically a screening tool that you can do in your 10-minute, 15-minute consultation. I've worked in England before where I got 10 minutes per patient, sometimes 15 minutes. Right now, I get 15 minutes for my general practice patients. But when I get patients referred to me, I get 30 minutes. So it's kind of easier in that sense. But again, like you said, the people who are referred to me for my women's health practice have already been screened. So they are referred for those menopausal concerns. But in my general practice, if they're coming for something else, so say they're stressed. If it's let's say a 40-year-old woman, for example, and she says, "Oh, I'm stressed," I'll first ask her if there's any change in her periods, if she gets hot flashes or night sweats, any change to her like a vaginal symptoms. Does she have vaginal dryness? Does she have like incontinence with her bladder? Does she sleep okay? And how is her mood? So those things are kind of rapid fire, but it's also, if the first question I ask her is, have your periods changed? And she says yes, my antenna is up, like, ooh, what's next? And then if she says hot flashes, girl, my answers are more. Exactly. So that's how I go about it in my family practice.
That's good. That's good to know, because I feel like sometimes women come to me for other things like thyroid or parathyroid disease or something else. And along the line, there was one particular patient I had. She came to me and she was just like she was having word finding difficulties. And I'm like, what's wrong with you? Like, talk, woman. And she's like, I don't know, man. The last couple of months, I just can't focus. I'm struggling with finding the right words. And that was like, you're 44. That was how I started asking her. We went down the line and she's been having hot flashes. She's been having mood swings. She's been having all these things. And nobody has actually asked her anything about it.
That's exactly it. Like, if you don't ask, they don't think it's part of the things that they should tell you.
Yeah.
So,
and this is the part that honestly drives me nuts, because I'm like, if you have an OB-GYN or you have a primary care doctor, why are they not asking you these questions? I can only imagine, because I probably see like 5% or 1% of women that come to me for other things. What about the other 99%, the other 95% of women who don't have particular endocrine problems
Yeah.
that, it baffles me a lot. Another question I wanted to ask you is, how comfortable are you with initiating hormone replacement therapy? Is this something you do routinely, or do you feel like you need to refer them to endocrine? And when do you refer to endocrine?
So I do, I'm like super comfortable. In fact, sometimes I encourage them because some people, yeah, because sometimes some women come in with because usually when it's like, I don't know, then I'm like, you've read something somewhere. Tell me, what did you read? Let's talk about it. And then when we're done with facts, because we only do evidence-based medicine here, when we're done with facts, they're like, oh, really? And then they understand better. So I'm super comfortable. I love encouraging my patients to do hormone therapy if I feel like it's going to be beneficial for them. In terms of referring to endocrinology, I mostly only do that when I want, like if they have osteoporosis, for example, and they failed the 2 oral medications that we have available, which are alendronate and what's the other one?
Ibandronate, Boniva?
No, we use risedronate here actually.
Oh, okay. Okay.
Yeah. So if they failed it, because it's kind of the next one would be an infusion, but it takes a while to get in for an infusion. And I love my endocrinologists around me. Like they are, I love smart women. They're all the ones that I refer to are the smart women. So I know that my patient is going to be well taken care of when I refer to them. But yeah, I mostly refer for, I would say that's when I mostly refer would be osteoporosis, just for a second opinion or for the new therapies that we have, because I'm not very versed in the new therapies that we have.
Jubanti, somebody is asking in the comment section, Jubanti. So Jubanti is denosumab. It's a brand of denosumab, yeah, but it's an injection. It's an injection every 6 months, and it's one of my favorite medications.
Yeah, I like it as well, but I refer to endo for that.
Yeah, I love it. I love it. So we use Prolia a lot, but sometimes insurance will be like, no, we're not doing Prolia. We're going to do Jubbonti. It's still denosumab. It's a brand of, it's like generic form of denosumab.
Awesome. Okay. Yeah.
All right, cool. My third question for you is, when you are counseling a patient on hormone therapy, how do you weigh their cardiovascular and bone health risk in that conversation? I think you touched on it a little bit.
I hope my patients are not watching this, because I always say to my patients, I am very, very strict with women. I do not joke with their LDL. What I will let a man get away with, I will not let a woman get away with it. So if I'm looking at your risk profile, so like if your blood pressure is high, first of all, we are addressing that before you leave that room. If your LDL is high, if your lipoprotein A is high, we are addressing all those things before you leave the room. Sometimes you do lifestyle and lifestyle doesn't work. And you have to, let me ask you this question. How do you deal with the controversy around statins right now? Because girl, I am struggling.
I am glad that I'm an endocrinologist.
I am struggling.
I'm glad that I don't really have to deal with that, even though we deal with metabolic health, but most of the patients have already been seen by their primary care. That has been addressed by their primary care. It's very rare for a woman to come to me. I bring it up. If I bring it up and I tell you the facts and you're still like, you don't want it because it's going to increase your risk of diabetes or this or that.
Dementia is the big one now.
Yeah, dementia, diabetes, all sorts of things. And I'm like,
so it's a little bit harder for me now to convince women to go on statins than it was even a couple of years ago. I'm not going to lie. It's much, much more difficult. And I usually tell them, you know what else is going to cause dementia? Like your blood pressure being high.
Oh, yeah. Vascular dementia.
Exactly. So, I mean, there have been so many studies. There's no evidence that it causes dementia, but it's so hard to convince people. It's very hard to fight against online
misinformation.
It's very hard. I'm not going to lie.
Misinformation.
But with your question, basically, when we go based on numbers, like we use the Framingham risk calculator. Mm-hmm. So if you're intermediate risk or high risk, I'm like, I just bring out the statistics of women. Like heart disease is the biggest killer of women worldwide, not just in North America. I'm like, you may not get, some people just die. Some people are lucky, they have a minor heart attack, they have a minor stroke. Some people are not that lucky, they just die. And even if you are lucky, you get a minor heart attack or something like that, the morbidity risk is very high. So you are not going to be like you were before. There's a disability that comes with it. So it's encouraging women and using facts rather than scare tactics. But yeah, I am very strict with them when it comes to like their cardiovascular risk and encouraging them to go on hormone therapy, especially if they are in that optimal age before the age of 16.
Good. Or at least 10 years within
10 years within their last menstrual period. Yeah.
Correct. All right. My next question for you, from the primary care, what barriers do you see Black or lower income patients face, specifically in getting to a menopause specialist?
Thank you so much for this question. I've been doing this for a couple of years now. I've seen
Tell
3
us,
Black patients.
how long have you been practicing?
I've been doing this menopause thing since 2024. I've seen 3 Black patients. I've seen 3.
Is it because you're in Alberta?
You would think so. However, I am in Calgary and there are a lot of Black women. And because I'm a Christian and go to church, when I talk to women in church, they are struggling with these things. When I go out to the community, they are struggling with these things. One of the women who was referred to me didn't want to be there. She didn't want to be there. She only came because she really respected her primary care physician and she just wanted to hear the options. She ended up not going on hormone therapy, even though I think she was telling me at the time she got 6 hot flashes an hour. She was sleeping a couple of hours a night. I think it's a combination of stress, but also the environment, I guess. It's very upsetting to me and my homegirls because Black women suffer the most with hot flashes, but they're also not really seeking help. And I'm trying my best to change that. That's why I make all these videos online. That's why I talk to women when they're, struggling. I once saw a Black woman having a hot flash in the middle of Walmart. So I like to mind my business. Like, I know I present as an extrovert, but I'm very much an introvert. I hope my nieces are not watching this. I'm very much an introvert. I don't like to talk to people outside. But I had to go up to her and be like, ma'am, you're having a hot flash. She was like, oh, yeah, I've been struggling with it for a few years. Well, have you spoken to your doctor about it? She was like, oh, no, it'll pass. My mom went through it and it was fine. So I don't get a lot of Black patients. And do you have any advice on how we can change that, apart from what we're already doing?
Apart from what we're already doing, talking about it, dispelling the misinformation, honestly, it still baffles me because I feel like that women's health initiative study, oh my God,
it really did a lot of damage. Yeah.
And still, like years after the studies has been done, years after all of this, people are still struggling to believe that this thing can actually help them. Honestly, one thing I found really rewarding when I started practicing as an endocrinologist, menopause care was one of them. It's like one thing that you can treat that not only the woman benefits, but the whole household benefits. The husband
They'll literally come back and tell you, you've changed my life.
Yeah. I had a patient, the husband, so I diagnosed her with menopause, put her on hormone replacement therapy and everything. And then I think maybe a month or 6 weeks later, we had a follow-up. And she was like, hold on, somebody wants to talk. It was a telehealth. She was like, hold on, somebody wants to talk to you. And I'm like, who? A husband. And he was like, thank you for giving me my wife back. Oh my God. That was like, I'm like, so
it's so rewarding.
It's so rewarding, not just for the patient, for their husband, for their children. And their co-workers.
When I bring my mom on my channel, because if she had, mom, if you're watching this, you did your best, I know. But that's why we're trying to change the narrative. We don't have to suffer as women. Let social media not be don't take my word for it. Check out the actual studies from the scientists that have done studies on thousands of women. It's not just, people will say all sorts of things. You can literally just wake up and say, breast cancer is caused by drinking milk 5 times a day. You can literally say that. Nobody's going to check you online. But there are people who are going to believe, they're just going to take that and run with it. And yeah, I've digressed so much from your question, but the point is, we need more Black women to seek help for perimenopause and menopausal stuff as much as other ethnicities, I would say.
My dear, apart from women seeking help, we need to equip the doctors. I feel like the training that we receive is
Yeah.
not good enough.
Yeah.
I'm going to tell you my personal story. I finished residency, 3 years of residency. I never saw one woman with menopause. In my
Wow.
fellowship as an endocrinologist, I got a 30 minutes lecture. A 30 minutes lecture. And it was even a Zoom lecture. It wasn't an in-person lecture. It was a Zoom lecture. And the woman was like, how many of you here feel comfortable prescribing hormone replacement therapy? And we were like, not me, not me, as an endocrinologist to be. Most of the things that I've learned regarding hormone replacement therapy are post fellowship trainings, lectures, courses, books, fellowships, conferences that I've gone to literally equip myself. Personally, I give grand rounds at my hospital, and I'm trying to encourage the residents, women's health. This is a condition that every woman will go through in their life. 100% of women who ages enough to this age will go through menopause, even if they're not having the hot flashes, if they're not having the poor sleep, if they're not having night sweats. Metabolically, things are changing.
Tell me about it. I think, let me tell you my own story. So first of all, my teenage years, I'm telling you, I'm going to bring my mom onto this show. However, when I got into residency, I was so lucky that my supervisor was, she was Dr. Roberts. If you're watching this, you probably are not. But if you ever watch this, hearts, she got me interested in menopause. And just seeing women's lives change, I was like, yeah, this is a rewarding part of medicine for me. So her doing that for me in my first year of residency, she was my supervisor in my first year of residency. And that's how I got into, we didn't do it in medical school. It was just one of those, it's just part of the lecture.
0% in medical school.
In women's periods, you just know menopause is 12 months after your last menstrual period. That's it. It's not a topic.
We spend all this time learning about purines and pyrimidines and all this abstract preps. But we never see those things. And then honestly, I feel like, so when I gave my last grand rounds, it was to medical residents. And I asked them, how many of you feel comfortable treating a woman going through menopause? 0.
Wow.
0. So it's not just about women not seeking help. When they do seek the help, they are met with blank stare because the doctor doesn't know what to do about it.
Yeah. And I think it's not even just the doctors. Well, I mean, it is the doctors, because if I'm coming to you and I tell you I have hot flashes and you tell me it's just stress, I'm going to go outside and find help somewhere else. And then
I'm going to go home and suffer through it. I'm going to go home and suffer through it.
I'm going to go home and suffer through it. I've had people come to me on some cocktails I've never seen before in my life, because they were so desperate because they spoke to their doctor and their doctor was like, sorry, them's the breaks. I can't help you. So they come with cocktails I've never before seen in my life.
Or it will go away. It gets better. After a few years, it will stop. You just have to toughen it. As long as this is this. Sometimes women don't even have the right words to explain this.
And that is it, right? And they are still hurried out of the room. And I think it should be part of residency. It should be part of residency. It should be part of residency. And I don't know how we can change that. I don't want us to be all talk. I mean, we are doing what we can. We're making the videos.
I'm doing what I can. My last grand rounds, I made sure I talked to the residents. I'm like, this is something that every woman will go through. You got to be able to do it. Yeah. When a woman tells you, I just don't feel like myself, or I'm getting a little bit more irritable, my patience is shorter, my temper is shorter, she doesn't need to open her mouth and say, it's been 12 months since my last period before you know that something is going on. Yeah. Just the way Dr. Roberts taught me about this, I am teaching my students. That's
to my
exactly what
residents.
I'm doing
So
too. That's exactly what I'm doing too.
hopefully the story will change in the next, I don't know, 5 years, because it takes time for things to move in medicine. So
Keep doing your part. Also, I want to say congratulations. I watch all your videos. I click all your
thank you.
buttons. I think you're doing
Thank you.
amazing, and I'm really proud of you.
Thank you. I love watching your videos as well. I love watching your videos. I love watching smart, beautiful women.
Thank you. Thank you. So
I
this
think we
is
should do this again.
I think so too. I think maybe we could do it once a month. It doesn't have to be menopause. We can talk about something else, you know. We can ask our audience whatever they want us to talk about. And
you guys can message us if you have any questions. Please follow Dr. Damage. She's an endocrinologist who knows things and posts videos. You post every day, don't you? I feel like I see your videos
most days. Some days I'm not in the mood, but I try.
I promised myself that I have to post every single day this year.
Did you do that A to Z, like A to Z of menopause thing? Like you're gonna go through every letter?
The thing is, I've actually already done it in January. I already did it.
So you have the videos.
I have the videos, but I only had maybe
thank you, Hallie.
Followers.
Hallie D, thank you.
Oh, thank you. I'm not even
We're not looking at the comments. We're not looking at the comments.
Just talk it. Yeah.
We don't know how to do these things.
So I already had the videos since January, but I only had like 70 followers. So I posted something the other day, and then somebody was like, "Oh, we haven't seen the others, so post one every single day." So I'm just posting them. I've already done them.
Good.
So yeah. So, but I have to post every day this year because I promised myself. But on January 1, 2027, you're gonna take a break. I'm gonna take a break.
Well, it's been a pleasure talking to you.
It's been awesome. It definitely went better than I was expecting because I was a little nervous. So
me too. I was a little bit nervous. All right. Awesome. Well, thank you everybody who joined. Thank you everybody who commented. Please feel free to send us messages. I cannot give medical advice in DMs, but I can guide you and give you general advice. Yeah, we can't give you specific medical advice, please. Thank you. All right. Thank you, Doc. Thank you. Good night. See you later. Bye. Bye.